Let me introduce you to my partner, Aaron Connor. Aaron is a seasoned litigator. He heads up the litigation department at Pierro, Connor and Strauss, doing guardianship, will, trust contests, other estate-related litigation. He also does long-term care planning and other estate planning in addition to that. He advises clients and is part of our long-term care team. And with that, I give you Aaron Connor.
Thank you. Thank you, Lou. As some of you may have heard, the transition in the CDPAP program has been less than seamless. And this is an issue that we've confronted for a while now. This is the clicker. And we, over the years, have followed a client of ours, Stan, who 2 years ago was trying to get care. And Frank had helped him with that, Frank Hemming, who does our Medicaid work. And then last year, we were able to report that Stan had had a successful fair hearing and gotten his hours. However, with the CDPAP transition, there were some bumps, and we wanted to give you an update on that. So that's what I said. He's from my hometown of Waterford. He lives near the canal, and he is a fighter. He saved with the idea that he was going to private pay for some of his care. And a lot of people in Stan's situation wouldn't have been able to advocate for themselves as strong as he has. And that is one of the things that really gives you an idea of who he is. So as I said, he got his, and he actually got reimbursement, which John McDonald was instrumental in getting him. He had to introduce a bill to have that happen. Yeah, it's pretty rare, but John really went to bat for him. And then, as I said, we've had some issues. So Beth did a wonderful video, and I want to give that.
Hey, so Stan, before I get your breakfast out, let me get your meds. Yep. All righty?
All right.
Stanley relies on 3 aides for 16 hours of daily care.
Breakfast out, let me get your meds.
Yep.
All righty?
All right.
Stanley relies on 3 aides for 16 hours of daily care. He personally hired them through the Consumer-Directed Personal Assistance Program, CDPAP, to achieve his most important goal.
My main goal is to stay in my home.
A home that has been in his family for 104 years.
Grandmother, grandfather, my mother.
Getting care at home wasn't easy. Stan spent months battling his managed long-term care plan to have Medicaid cover his care. Then came a new challenge.
Hello, thank you for contacting Public Partnerships, LLC, also known as PPL.
New York State chose PPL to manage CDPAP, replacing hundreds of fiscal intermediaries.
New Yorkers will get better care and better service at a better price. That's the truth.
Stanley and hundreds of thousands of consumers and their aides had to transition. When PPL's portal opened in January, Stanley quickly set up accounts. But weeks passed. Stan noticed he was only approved for 32 hours of care, far short of the 112 he needs. Emails and faxes didn't resolve it.
The point of getting frustrated.
And when Stanley gets frustrated, he doubles down, hiring care coordinator Nina Crisanda.
And I was the squeaky wheel. So I spent a lot of my time on hold with PPL.
We appreciate your patience. Calls are answered in the order they are received. A representative will assist you as soon as possible.
And I would just listen to their hold music until they kicked me off in 15 minutes. And then I would call them again. And I would call them again. And I would call them again. And again, and all of days and days and weeks of this have gone by. I did get one call back.
After many calls, Nina got Stan's hours corrected, but his aides still lacked access codes. Paychecks were delayed.
For a couple of weeks, I would say my time was a little messed up and they had to back pay me on something.
Stan reached out to Assembly member John McDonald for help.
I will not be the first one to tell you it went very easy. It did not, by any stretch of the imagination. You know, let's make sure that people get paid.
McDonald contacted PPL to get Stan's caregivers paid, saying this case is an exception, not the norm.
The nice thing about Stan is we were able to reach a resolve. What I don't hear is that people are having no problems whatsoever, that everything's going along just ducky and just fine. And you know what? There's probably 260,000 of those people out there, and I'm glad that things are going well for them.
1, 2, 3.
Stan is relieved the CDPAP transition is working better, but says it shouldn't have taken 3 months and outside help. He feels the state rushed the rollout.
They think that something of this magnitude can be done by overnight. And it can't be.
So thank you, Beth, for that very good video, great video. I think we can get the sense of what Stan's going through. And to be fair, PPL was invited today. They declined. So, but I now want to introduce Al Cardillo. He's the president and CEO of the Home Care Association for New York State. He has over 40 years in health services development, administration, policy, and association management. He's also an adjunct professor at Albany College of Pharmacy and the University of Albany and an MSW. So Al, you're up.
So I have to say, I don't know that there's anything that any of us here can say that is more profound than what that man just said about his experience. And thank you very much for queuing that up. That really has to be the focal point of what we're all about and what the government officials are about who came today, and really what anyone and everyone should be focused on in Washington, D.C. as they work through this process. So just you know, I'll suspend what I was going to say up front because that was just profound. I've queued up a slide here because I also think this is very important. Senator Lombardi, really, there's no one in the United States that did more to launch home health care in the modern age of home health care than Tarky Lombardi. Senator Lombardi decided he was going to, at the age of 95 in November, do some work with the Lord. So I hope he's looking over us and that he's providing some good guidance for where we could go next. So in today's remarks, and I'm just going to really set the table because as we set up this panel, it's going to kind of get a lot more detailed and really focus on consumer directed specifically. But I want to really lay a little broader landscape on home health care. And I want to focus on a few different things. Number one, some good news. You know, what is the good news about our system and where we are? The second thing is, you know, what does the current landscape look like? What are the state of affairs? And then finally, what are some opportunity areas? I know it can get very glum in the process, but we need to look up, we need to look forward, and we need to act in a forward way. Go back. Oh, there. Okay. So the first thing is that home care is the preferred setting. Right? So 9 out of 10 New Yorkers that have been surveyed, people over 50, would prefer to receive home care. So we know that this is really the future in the system for how our healthcare system should be oriented. Secondly, this is the field that is the growth field for occupations. And we know that while we're struggling to employ people, it is the place where the future demand is perceived. So from a labor standpoint, this is the place for the future's investment. Cost effectiveness. CMS forecasts the value-based payment program that was put in place by Congress for home health will save over $3.4 billion in the period between 2024 and 2027. You'll often hear just about the cost. Oh, home care costs a lot, but we don't hear what it really means in the system. And this is just one component. And these costs, by the way, are achieved through improved outcomes, and improved use of alternative high-cost services like hospitals that the value-based program allows and facilitates. An independent evaluation, the Money Follows the Person program, shows that people that transitioned from nursing home to home under that program resulted in a decrease of spending by 20% during the first year and 27% the second year. And a message right now for Congress is that when there are reductions in caseload, so for example, if you reduce the caseload by 5%, it's over $6 billion more in terms of what the costs are. So again, it's very, very important for us to be able to grasp what the strengths are of the system, what it means for the future, and really to work from that type of a base as we go forward and as we advocate. The other part of the good news is that there's tremendous innovation going on in home care. Louis talked about, the level of application of technology in the field. We heard the wonderful panel earlier talking about PACE and some of the programs and projects. The last panel talking about financing and ways to finance. But within home care, there is advanced care going on all the time. Care that just a few years ago only could have been done in hospitals, whether it's wound care, whether it's assisting individuals that are on ventilators, post-surgical, pre-surgical care. It's the innovation within home care is really flourishing going forward through technology, artificial intelligence, new skills, new application of services. The other thing that is critical is that home care is really a very powerful collaborative partner with hospitals, with doctors, and other partners within the system. And those collaborations are really resulting in very, very transformative models of care, very transformative practices. I've linked in this slide here a couple of documents. One is a document that is a compendium of hospital, home health, and physician collaboratives that are flourishing in the state that are really having some of those transformational results. Another one is a program that we are currently implementing with the Iroquois Healthcare Association and IPRO that we call collaborative models of community medicine and paramedicine. And in this model, hospitals, home care agencies, EMTs, and physicians and other providers that would like to be partners are working together to try to cover the gaps, improve care transitions, provide services in a more coordinated way than if every part of the healthcare system continued to just operate as silos. What we typically find is that providers coexist in communities, but they don't necessarily collaborate. So I want to just show you the results of some of the recent studies. What we found is that in these 7 area projects, so it's really upstate from the Mid-Hudson all the way to the Finger Lakes, there has been a 78% reduction in hospital admissions from this kind of collaborative care, a 61% reduction in emergency department visits by these individuals, and the statistics just go on. I encourage you to access this document, take a look at it, and I think we need to build this into a perspective and a frame of reference that's optimistic about where we are and where we're going. But now for some of the daunting side, because we certainly can't ignore this. In this chart that you see here, the line that goes up are compounded cuts that have occurred in the home health care benefit on the Medicare home benefit from 1920 through the end of this last year. When you look at those cuts, it's over 20% in the Medicare home health benefit. If this trend continues, and this is not something that Congress is looking at now, this has been in place and been eroding. If this continues over the next several years, the total amount nationally is going to be $25 billion in reduction to home health. And it's been forecast that about 50% of all agencies in the country will run in the red. At the federal level, I'm not going to go through the details of this slide, but at the federal level, we know they're looking at $880 billion further in the Medicaid program. And on top of what we're already seeing, that's certainly a great concern for us in our field. One of the things that is currently at play is that many of the cuts on the Medicaid side are really in more broader categories, like they're described as provider taxes, for example, or might be in some across-the-board category of federal share and federal support for states. While in that, you don't see a direct connection to potential cuts in the services. The reality is that when states have to deal with a reduction in Medicaid, states will be having to make some very, very difficult decisions about what to fund, how to cut back, and so on. And certainly home health care has not been in the favor of state funding in recent years. So I want to show you this slide. So where do we stand in an industry right now? 58% of the Medicare, Medicaid certified home health agencies in the state are below margin, and they're significantly below margin. In the last year, providers have closed, and I think this is just since the end of December. Providers have closed, resulting in 16 upstate counties losing the service of the agency. Since that time, 2 more providers closed about a month ago in the Mid-Hudson Valley area. This is a trend that is growing and continuing. It's estimated that since 2020 to 2023, 188,000 individuals that could have been referred or were referred to home care in the state did not receive those services. These graphics right here were developed by the visiting nurse service of VNS Health, and it basically shows what I was just describing, but it also shows, it'll give you statistics from across the state in terms of what the patient access impact is of these diminished financing. If you look at the top statistics there, a decrease of nearly 25% in home health access from 2019 to 2023. So that is only worsening if you look at the chart that I had earlier that showed the upward trajectory. This series of graphics focuses on the percentage of unfilled positions and the percentage of turnover. What you'll see when you can look more closely at those numbers, you'll see that you're in the upper 20s to the 30s in terms of percentages of vacant positions, nursing aides and other, as well as the turnover rate in terms of the loss of personnel in agencies. And as folks have really emphasized throughout Lou repeatedly, you can't deliver care if you don't have the personnel. There's only so much you can really do with technology. But these are the consequences of that kind of underfunding. Of course, this is the elephant in the room, the major change that has occurred in the CDPAP program in a 1-year period of time. And I'm going to really defer to my fellow panelists in talking about that in greater detail. But I think we're aware of, the growing impact and the concern about where this lands and how this is going to fall into place. And again, the opening video, put that in a perspective that none of us really can, better than that individual. Just want to make a word about the budget, and maybe 1 or 2 slides, and then I want to defer over to, again, my fellow panelists. So in terms of the state outcome, about $1.4 billion was added in state funding, enhanced state funding from the MCO tax, the managed care tax, which was approved last year by the legislature. How much did home health get of that? Do you see that 0 there? That's the amount that home health got from that $1.4 billion. About $600 million of that went to the hospital sector. We love hospitals. We need hospitals. But 0 went on the home health side. The legislature did try to include funds for home health in that mix, but they fell out at the very end of the budget negotiations. We have legislation to try to provide the programmatic stability for that. Next time we can talk about funds, and that's a part of the mix. The executive proposal also put a cap on the nursing home transition and diversion program. That is the only program that right now exists outside of managed care as an option for individuals, yet that's capped in the final analysis. Money was eliminated from the quality pools under the managed long-term care and under PACE, and it's unclear right now whether any of that was restored. We think some of it might have been, but it's an administrative action and we can't track it down. Also, there were multiple workforce initiatives that the governor had in the proposal. Only a few really squeaked by in the end. One last thing I want to just reference, one more slide, and then I'll switch places. The executive proposal had a proposal for what's called hospital at home. As I mentioned earlier, there's tremendous work being done in hospital and home care collaboration in this state. It's tremendous. But the governor's proposal would allow hospitals to overstep the requirement to work with a home health agency, the requirement that right now under New York law, to provide those services in the home, you have to be a licensed or certified home health agency. In this proposal, you get to skip over it and provide services in your own way, basically. That is a proposal that we've again tried to encourage the governor. You need to preserve the proper role of home health agencies, of home health staff in the care of patients at home. Fortunately, the legislature omitted this proposal from the budget. We are worried that it comes right back out. We want to work toward an amiable solution, but we don't think the solution is to lie down, play dead, and basically circumvent what is a sacrosanct part of the system. Just this last slide to maybe focus on, which are areas of opportunity. Right now, there's major opportunities for regulatory relief federally. The Office of Management and Budget has basically done a call for proposals for regulatory relief, and Medicare is going to be doing that. I think it's due on June 10th. Those are great opportunities to figure out how do we get out of some of the strangleholds so people can provide services, as those services are needed. There is also, again, opportunities in the master plan for aging that would be coming at the state level. Further opportunities in technology, AI, and the capabilities associated with AI. And just the last slide I want to show you is a picture I took when I was in Ireland last year at this time. I missed your conference, Lou, but I came back with this quote from Martin Luther King, which was in the window of a clinic in Donegal, Ireland, which is that if you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to keep moving forward. Thank you very much.
Thank you, Al. Great stuff there. And, as the access to home health care is going down, the people who need the home health care is going up. So it's really exacerbating the problem. Next up is Frank Hemming. He is from the law firm of Pierro, Connor, and Strauss. Frank has been with us almost 10 years now. 10 years. It is 10 years. I stand corrected. It just feels like 9, though. My first year was just totally great. Frank does all of our Medicaid work. We affectionately call him Mr. Medicaid. He is a frequent Life Happens radio guest, and he's going to talk about how we access this care.
All right. I love doing this stuff because it forces him to say nice things about me. But it's nice to be here again. It's great to see so many people that I see every year at this conference. I was thinking earlier that while it's the 30th edition of this forum, it's my 10th. So while I think I haven't been doing this that long, it's been a lot longer than even I realized until I kind of get in a setting like this. So me as a planning attorney, what I like to educate people about, counsel people about more than anything is Medicaid and protecting benefits, accessing benefits, and getting the care that people need. So I frequently do a lot of lecturing on either chronic care Medicaid or nursing home Medicaid or community Medicaid, which in this setting is generally going to be home care. But obviously, if you're in the audience and you do this work as well, you know that it can apply to a very limited amount of assisted living benefits, but it also gets you other things like adult daycare and obviously your home care benefits in the setting that people want to be in. So I'm going to do my best to stay positive because at the end of the day, right, let's try to get some nice news at the end of the day, but we'll see how we do. So I know you haven't been hit with a lot of numbers today, so I want to give you some more numbers to take home with you because I don't think we've actually thrown these around too much today. So at the beginning of the year, we get increases for cost of living for our income allotments and our asset allotments for Medicaid. And again, they did go up a little bit. They didn't go up a ton, but they did go up slightly. So if you're a single person getting help in your house by Medicaid, your income allowance is $1,820 per month. If you're a couple, it's $2,453 a month combined for both spouses. If you're a single person, your asset limit is just above $32,000, so it's now $32,396. And if you're a couple, it's up to $43,781. Again, just to put this a little bit in context, my first forum, so 10 years ago, the asset limit was about $14,750. So while $32,000 isn't a ton of money, it's more than doubled what it was 10 years ago. The income allowance was, I believe, around $800. So again, that's roughly doubled in 10 years. So again, while these aren't bigger numbers, they've at least gone in the right direction in that period of time. So one of the biggest things that I think, get to surprisingly tell people to their benefit when they need Medicaid is that a lot of the things that they have might already be exempt for Medicaid, and they don't count toward your asset allotments, and we don't need to actually do anything to protect them. So obviously you get your up to $32,396 of your assets. And then one of the biggest assets that people have that they're generally most concerned about is their house. And their house remains exempt as long as their spouse or minor disabled or blind child is living in the house. So for many, many, many people, if you're somebody who works in this industry, or if you have people that need help and you want to help get them qualified, one thing that you may not think you need to do much, or that you may not need to do a lot about from a planning perspective, is the home. If they're in the home is exempt for Medicaid qualification purposes. Now, that doesn't mean we don't want to do some other potential things down the road to make sure there's no asset recovery against that house when they pass away. But for many people, just seeing that very low number of 32,000 makes them think, I'll never get Medicaid. I have a nice house. Well, if you're in your house doesn't count. You can have one car, regardless of its value. So you could have the Lamborghini parked in your driveway or in your garage, and congratulations, if that's all you have in your house, you can get Medicaid. So one of these days, we're going to find a client that's in the nursing home that wants to look at their Ferrari out their window, and they could be on Medicaid and look at it from their nursing home window and have Medicaid pay for it. We haven't found it yet, but we will. You can have a prepaid burial because, unfortunately, time comes for all of us. Medicaid is not incentive enough that they don't want you to be able to pay for your arrangements. So you can prepay in any amount for your burial. You can keep an income producing property. Typically in our practice, this would be a business. So if you do have an active business, as long as it is active, your business is exempt as an asset. The income you derive from it may not be exempt. And it would count towards your countable income. We'd use other types of trusts to deal with that, something called pooled trusts. I'm not going to talk about that because that's why Sarah's here. And then obviously, last in that column, without the big stuff in red, is your life insurance. This unfortunately is a little bit of depressing news. You can only have a very limited amount of life insurance. So if you have life insurance with face value less than $1,500, it is exempt. But if it is over $1,500 of face value, it is not exempt. It counts as an asset. But the reason why the bottom part is in red is because we like to make this very, very clear and very, very important point to our people when we're educating. And that is if you have a retirement account, so that is pretty much any tax-deferred money, IRA, 401, 403, 457, if it's in payment status, it is exempt from qualifying as an asset for Medicaid. So if you have a client that has a house, $10,000 in an IRA with $3 million in it, congratulations, they are Medicaid eligible because the IRA doesn't count as long as it's in payment status. So do not have your people pay down their IRA without talking to somebody qualified to determine whether they are Medicaid eligible, because the IRA does not have to be spent down. Other good news. Wow, I know we've had a lot of talk about cuts, PPL enrollment, all the stuff that Al just talked about, but we still do have a nice open window of opportunity to get people on home care benefits, at least from a planning perspective, because while all that other stuff is going on, at least they have not instituted the 30-month look back that was supposed to be coming. Because I don't know if you remember, but back in 2020, they passed rules to put a 30-month look back in place for home care. So far, they have not done that, and there has not been a lot of direction towards implementing that as of now because they have a few things going on. Okay, but again, that's hiding in the background. So again, if you have people in your life, yourself, your children, friends, this would still be a time to get qualified for Medicaid if they need it now, because we can do it without any penalties, or at least setting yourself up for success in the future. So how do we do that? We talk about trusts. As attorneys, love doing trusts. We love talking about trusts. We love creating trusts. So typically we use and fund something called an irrevocable trust to get people qualified for Medicaid. It's used to hold their assets, like their house, like their stock, like their life insurance. So the way that this works is we typically have them come in, we have a sit down, we go through their assets and we talk about what goes in such trust. So we could put in all different kinds of things, their house, their cash, their stocks, their CDs, their annuities if they're not tax qualified, all right? We typically allow them to get the income from their trust, so it doesn't change their income picture at all. And we structure the trust in such a way that any asset inside that trust can be accessed for that Medicaid beneficiary. It just can't go directly to them. So typically we use children, other family members, or trusted friends that can be used to pull money out of the trust, receive it for the Medicaid person, and then turn around and use it for their benefit. As long as the money doesn't go directly to the Medicaid person, this typically doesn't upset any Medicaid rules and should work just fine. It can also, this type of trust can also hold life insurance if you have a business, if you have additional real estate, but it can be used for all different kinds of things. And ultimately, and honestly, it's the biggest tool that we have in our toolbox to make sure that people get the care that they need by qualifying for Medicaid. We keep out some cash because again, you can have some $32,396 or less. You keep out your retirement account because as I've said several times now, that retirement account, it's exempt. You don't need to put it in trust to protect it. And the best thing about this trust is not only does it protect your assets after 5 years from a nursing home, it creates immediate eligibility for home care. But we also give you other powers inside the trust. So I can tell you one of my favorite parts in a meeting when we're talking with either a single person or a family, when we're going through the trust, is when I threaten to fire their children if they don't do what they want from their trust, right? Because at the end of the day, there's typically a lot of anxiety that goes around the creation of these trusts, and people get very concerned about their ability to stay in their home or access their funds. And one of the best things I get to tell them is, well, if you appoint your son or your daughter or both or someone else and they don't do what you want, you can fire them at any time. And I'm more than happy to fire your kids. You can also change your beneficiaries, and that might be the other biggest power that they have. Sometimes even more important than the power to change trustee. Because if your son, your daughter, whomever really make you mad, it hurts a little bit to remove them as trustee. It hurts a lot to remove them as a beneficiary. All right. And then I always make the joke, right? But at the end of the day, I'm a lawyer. You can't always trust anything that I say. But in New York, we're very lucky to have a certain law in place that allows you to revoke a trust, even if it says it's irrevocable, as long as you get the consent of your beneficiaries. So a well-drafted trust can be undone if we don't get through the 5 years and we have some kind of crisis happen with a nursing home. As much as we're not planning for that, there always is another kind of avenue forward. So if you do your planning early, you can get your care costs covered. It helps avoid probate, keeps you out of court, which we lose that as the attorneys. We make money when you go to court, but we try to keep our clients out of court. It can protect your house. It can protect your assets. It secures that legacy, and it helps you make sure that your wishes that you want are followed once you're gone. So with that, I know that a lot of you in attendance are much more here to hear the rest of the panel. So I'm going to step back, but thank you for having me again. It was nice to see everybody.
Thank you, Frank. As someone once said, protect your house, call Pierro, Connor, and Strauss. All right. So in our world, in the Medicaid world, we have to divide the world between income and assets. And this is often a difficult concept for our clients to separate, right? Because sometimes income becomes an asset. So, right? So we often hear, oh, mom or dad makes too much money to be on Medicaid. That is rarely true. It could possibly be true if they were really, really wealthy, but more often than not, we're employing a pooled trust. And so to talk about that, we have Sarah Grimes. She's the Director of Business Development at NYSARC. She joined NYSARC in 2016 and works with pooled trust. She's a frequent speaker with us, and we appreciate that. Sarah, it's all yours.
Thank you. Thank you, Aaron. I can get these up. Thanks, everybody. It's wonderful to be here. Green button. This green one. There's two green buttons. Okay, not fair. All right. Good afternoon, everybody. We know we're at the end of the day, and there is some really important information coming up. So I want to keep things short and sweet, but high level for you. I think Aaron hit it on perfect. My number one takeaway that I want everyone to have is that very few people are not going to qualify for Medicaid, right? So even if we're, in a situation where we don't have a lot of assets and we don't have a need to protect assets, there are those people that are going to be in that middle ground, right? They don't qualify for Medicaid, but they don't earn enough income on a monthly basis to cover the high cost of these services, as we've all learned how costly they can be. And so we have to understand that there is always an option. There's always a solution, and it generally is going to be a pooled supplemental needs trust, unless it is a very small portion of the income that they're going to be over that limit. But just about everybody is going to qualify. So don't let income or a worker prevent you from getting access to Medicaid. I've had multiple people come up to me today and say, I was told I wouldn't qualify. We want to make sure you understand you absolutely can in most cases. And so it's important to understand, I think the key difference between the income and the assets is that the assets is something that you protect in advance of needing Medicaid, hopefully. That's what we hope, right? We want you to plan, right? And so those are things that you want to leave to your family, and those are things that you generally want to protect before you need Medicaid services. Your income is something that you're only going to be able to protect at the time that you need to qualify for Medicaid, right? So you're going to look at a pooled income trust when you need to apply for Medicaid services. And this is going to be a way for you to protect the amount of money that you are over that Medicaid limit. So Frank obviously showed us the limits earlier. If your income as a single person this year is greater than $1,820 a month, it's that amount that's above the $1,820 that you would need to protect in something like a pooled trust, right? And so if you're $1,000 over the limit, in this case, we have a quick example. She's $1,800 over that limit. Giving up that money is going to make it very difficult for someone to be able to continue to afford to pay their bills. Right? You can turn that money over to Medicaid, but now you don't have it to pay for your expenses. It's going to make it difficult for you to be able to live in your own home. So depositing those funds into a pooled trust is going to be that solution. Every month, you're going to make a deposit into the trust. That's going to allow that person to qualify for Medicaid services and use those funds for the things that they need it for. Household bills, items and services that are for them, allowing them to maintain their standard of living, continue to afford their bills, and live in their own home. Right? And it's important, we have a little example here. I'm not going to go into the details on this, but this is a number that is determined by Medicaid, right? And so this is something they're going to look at all sources of your income, and they look at gross monthly income. So you don't want to try and do this calculation on your own. You want to work with a professional or work directly with the Medicaid office. They're going to tell you right down to the penny exactly what needs to be deposited into this trust, right? So this is your Social Security payment, maybe pension. The distributions that you're taking from that retirement account are going to count as your income, right? So they're going to add up all of those sources of income. We talk a lot about older adults. It's not just older adults, right? This could be someone who's under the age of 65 who might be working and maybe part-time and has SSDI. They might have a little bit of extra income that puts them over that limit. Maybe they're not even just looking for home care. They could be looking for other types of Medicaid services, like a Medicaid waiver program, people using OPWDD services. And I've had a few conversations with people today who are in the Medicaid buy-in program for working people with disabilities, which generally allows you to have a little bit higher income. Some people are going to age out of that program right now. Once you're over 65, you're no longer eligible for that. So now your income may be above those limits. Hopefully that is going away soon, and we won't have that issue. But we do want to make sure that we allow Medicaid to make this calculation. They're going to also take out some deductions, things that you may be eligible for to take out of your income, like paying your Part B premium, that $20 disregard, which is available to people with disabilities. And then that's going to get you down to generally what you're going to need to deposit into the pooled trust. And then for the cost, the small monthly cost of using a pooled trust, you're going to be able to access all those Medicaid services, right? So in this example, instead of giving up for a little just shy of $1,500 a month, they're going to be able to access Medicaid services for just the $90 a month. Now, I want to talk about the steps just quickly of how to actually apply for the pooled trust. I got a little into this earlier. The first step, of course, is that you've got to get your assets below the $32,000. You're not going to apply for Medicaid until you're below that asset limit. But you do need to apply for Medicaid in order to figure out what your spend down is going to be. So again, we get a lot of people who are like, I need to set up a pooled trust, but I don't need Medicaid yet. That's, you're going to wait until you actually need to apply for those services. When you do have to have a qualifying disability to use a pooled trust. So that's a really important step. If a person is over age of 65, they're going to need to fill out some disability determination paperwork in order to qualify. A lot of older adults might not necessarily consider themselves to be disabled. Most of them will qualify, especially if they need access to these services, right? So it's a couple extra forms you fill out and submit with your Medicaid application. And then you're going to apply for your pooled trust. It generally takes about a week. When you get your spend down notice from Medicaid, you have until the end of the month to pay that spend down. So it's something that you can set up in advance, like when you start Medicaid application and submit it with your Medicaid application, but you can also set it up once you have your spend down notice. Or if you're someone who's already paying a spend down and you want to be able to stop paying that to the county, you can simply set up a pooled trust and then submit that paperwork to the county to show them proof that you're putting your spend down into the trust. And then you can start accessing those funds in your account to use it to pay your bills. It's what everybody wants to know about. What can we use it for? There's going to be a nonprofit that's going to manage that money on behalf of the beneficiary. It's got to be used for items and services that are for that person. We cannot give you cash out of the account. That would make the money available to you. That would make that money income and increase or potentially put your benefits at risk. So we're always going to pay a third party for expenses, items and services in your name. We're going to prioritize your basic living needs. We're going to pay things like your household bills, your rent. If you own that home, if you own that Lamborghini, we're going to pay those bills, insurances, property taxes, all of those things up to what we have available in the account. And when we talk about the eroding availability of home care services, sometimes it's also going to be to supplement the services that you're receiving, right? So you may be getting a certain number of hours. The pool trust may then use some of that income to help you supplement that care. And it can be used for quality of life things. It's not just your bills, but it is up to what you have available in your account. So yeah, it just in closing, you know, there are going to be some monthly costs to use the trust. Deposits will come out of your account with generally electronic deposit transfer from your bank account. Makes it really easy for you to meet that spend down. For some people that we turn around and pay it out to your rent automatically, it becomes a very automated process. You can make deposits as a one-time or set up those recurring. This is a tool that can also be used if you're on Medicaid and you have a windfall of money that you may need for your own expenses. You can protect it in your pooled trust. And it's also something that can be used by older adults who might be planning for the future of a child or a grandchild with disabilities. And there's easy ways to access the money. Most pooled trusts have a variety of different ways for you to be able to submit bills and request payments from the trust. So please feel free to stop by or call us if you have additional questions, but that's all I have for today. I'm going to turn things over to Val.
Thank you, Sarah. And I think everybody knows who Valerie is already, but I will just add two brief things that I don't know of anybody in the state of New York who knows more about what she's going to talk about. And she is an indomitable advocate for her clients. So, you know, if she's representing you, you're going to do well.
Thank you to Lou and Pierro, Connor, and Strauss again for having me and all of us in this terrific day. It's been very enlightening. So I'm picking up where Frank and Sarah left off in terms of the process about, so you're on Medicaid, and then what? And Suzanne and I will be talking about then advocacy on actually getting the home care. For one thing, there is this immediate need process that some of you might be familiar with, where you know, normally you have to apply for Medicaid. Oh, thanks. Normally you have to apply for Medicaid, go through the New York Independent Assessor, then enroll in a managed long-term care plan, and all of that can take 4 or 5 months. So to expedite things a little, you can apply for Medicaid and home care at the same time in a process called the New York Immediate Need Process. But you still have to go through this independent assessor. So this slide is about, there's some changes where you can apply for Medicaid, go through the independent assessor, and then go back to your county or HRA to say, okay, now approve me for immediate need home care services. So some tips with the New York Independent Assessor that we've talked about a lot in the last years, but now it's sort of, we're we're sort of used to it. But it's still a tough hurdle to get through. And this is another New York State contractor. They like to contract out. It's to Maximus. And they have a nurse do an assessment that uses a tool called the CHA, the CHA, the Community Health Assessment, and just some recommendations for getting through that assessment. Again, you've applied for Medicaid, you've been accepted. Now you're calling the New York Independent Assessor, the nurse is assessing you. For one thing, they will probably offer a telehealth appointment, but the consumer has a right to say, no, I want it in person. You might have to wait longer for that, but those can be more advantageous because the nurse can actually see the consumer, how they operate in their home. How do they get around? How is the home set up? So that could be worth pushing for. We always recommend that someone is there with the consumer to really point out their needs, whether it's a family member, a care manager, or some other representative. And this is really important because what we're seeing in these assessments is the nurses are finding the clients to be independent in ADLs, where you'd say, really? Like, this person is so at risk of falling if they bathe alone, if they get dressed alone without assistance. But so a few things come into this. For one thing, there's this 3-day rule. The assessor is told, only look at how the consumer performed that activity in the 3 days before the assessment. And let's say you say, well, my daughter comes twice a week and helps me bathe. So in the last 3 days, I haven't bathed. Therefore, in their eyes, you don't need help because you didn't have the task and you didn't have help with the task. Or if in the last 3 days, I took a shower, but it is so unsafe for me, I can't crawl over the lip of the tub and I'm so at risk of falling. Well, you did it. So you did it. You're independent. Nobody was there to help you. So this is, if you look in the instructions of their reference manual, and as far as I know, the most recent one is not online, but that's what it says. So it's sort of ridiculous. But we have to know that, right? So it's a good idea in the 3 days before the assessment, if the family, the consumer thinks the person needs help, they should have the help they need in the 3 days before. So that can be described in the assessment. They mislabel, they say someone's independent when they really need verbal cueing, especially with dementia, other cognitive impairments. So because cueing is a type of assistance, it's not, it still requires a person to be there if the person needs that help. But this often has to be pointed out or they just discount it. Then the New York Independent Assessor sends out these outcome notices that say, important notice about your assessment. It doesn't tell you this is a denial notice. So the person might just think it's just information, but no, this is a legal notice. And if it says what this one says is, you do not qualify to enroll in an MLTC plan, it's because it found that you didn't have these ADL needs. It's probably because the assessor found you were independent. Now, right now, there's no minimum number of ADL needs. But you heard before about the look back. Another change that we're waiting from 2020, one of the MRT Medicaid redesign team changes is a threshold that you will have to need 3 ADLs in order to get past this assessment. And in that assessment, queuing will not be counted when this actually takes place. Queuing is not going to be counted unless you have a diagnosis of dementia. So you will actually have to show the physical need for limited assistance, which includes contact guarding for 3 ADL. So it's going to be a much stricter assessment, and a lot more people will be denied. This has not been implemented yet because CMS, this is one time, it's sort of good that CMS has been completely plundered and there's no staff there, because it's the only good thing about that, because somebody there has to sign off that the state spent billions of dollars in COVID funding called ARPA in order for them to go ahead and implement these cuts. And nobody's there doing that. So that's the only good thing. Everything else is awful. So, but if the assessment says you don't qualify to enroll in an MLTC plan, what you can do is go back to your DSS or HRA and ask for services, but all you're eligible for is up to 8 hours a week. Because if you were eligible for full personal care or CDPAP services, you would have been eligible for MLTC. When they say you're not eligible for MLTC, they're saying, no, you don't get personal care, because MLTC is the only game in town. And so you have to go back and request housekeeping services. And this is the new fax number in the city for housekeeping. So these NYA assessments, independent assessors, only used for initial assessments when you're first entering the system or first asking for CDPAP. If you're already someone in the system and you want an increase, then it's going to be a managed long-term care nurse or a nurse from your local district who's going to do that assessment. Do you want to cover the increase? Is that partly what you're going to cover? So if you're requesting an increase, just to keep in mind that if you're looking for 24-hour care, that is one place where in New York we have very, very clear standards in our regulations. So it doesn't have to be like a mushy, oh, I need more care and mom needs help at night and she really, really needs help at night. Like, no, you can be very specific. There's a standard that the aide, to get split shift care, you have to show that she needs help with ADLs, toileting, walking, transferring, or turning so frequently that an aide at night can't get 5 hours of uninterrupted sleep and can't get 8 hours of sleep altogether. Like, that's a very specific standard. So that's the job of the advocate or the family to prove that. So then you know exactly so you're asking, well, how often do you have to get up at night? And why, the plans will say, well, just use double diaper. Well, why can't you use double diapers? Yeah, you actually have to prove that. Or why can't you use a commode? So there's very clear standards, and it's always best to make requests like these in writing, because there are time limits that the plan has to process them. And if you don't have proof of when you requested it, the plan can say, we didn't get the request. These are some other tips. I don't want to take a lot of time. I do want to point you to an MLTC policy it really needs to be in your toolkit if you do this advocacy, number 1607. There's a link there. This is all in your materials. That it really does help give standards of what you need to prove to get an increase. It says the plan has to take into account what needs can be scheduled, what needs occur at unpredictable times, which ones are recurring day and night. So again, you have a roadmap of what you need to prove. And when you talk about ADLs, you don't want to talk about someone just needing safety monitoring or supervision. You want to be very specific that they need queuing assistance with specific ADLs. Because then it's assistance with ADLs and they can't say, oh, no, you just need safety monitoring and we don't do that. Because that's what they'll say. And here's the appeals process, but I think I'm going to turn it over to Suzanne.
Thank you, Valerie. So Suzanne Paolucci is can you hear me? Oh, there we go. Suzanne Paolucci is an elder care consultant. She established New York Care Consultants in 2018. If you are downstate and you're not getting the hours that you require, you should call Suzanne because she has proven very, very adept at that. And Suzanne is the final new guest for today, although the last word still belongs to Lou when we're all done. So
I promise I'll be quick. I had one agenda for coming here. So social workers, raise your hand. Where are my peeps? Okay, I came to speak with you. I am a licensed clinical social worker, and it was important for me to come today because, one, I wanted to report on trends of what I'm seeing in the trenches, and two, what we can do to help that. I'm going to apologize to any MLTC caseworkers right now. I get the problems. I get the people coming to me because they need more hours. I don't get the calls, oh, I love my managed care caseworker. They're great. So if they love you and you're doing a good job, I'm not here to say that you're not. I'm just reporting what I see and a trend that's been bothering me that made me drive 3.5 hours to talk to you about it. What I'm seeing is people sign up, they get their hours that they're initially authorized, they're not happy with the hours, and they go to their trusted care manager and they say, my loved one needs an increase. And then they're thrown off course, okay? They're told that, well, you have dementia, I'm just giving you one example, you won't qualify in the MLTC program, you need to go to the waiver program. Okay, so now the waiver program's sinking and having a hard time and thinking about putting caps on services because the MLTCs are funneling our dementia clients off to the managed care program. And that's misinformation because Valerie touched on, if someone needs safety and supervision with an ADL, you qualify for services, you get credit for that task. So here we have a social worker or a nurse who is actively misinforming. They're sharing in the community that you will not get 24-hour care. It is impossible to get. And that's trickling down now to other social workers and case managers in the community who may be working in a subacute facility who now says, you will never get 24-hour care. So now the family is struggling to understand how best can I help my loved one? Is it nursing home now? Can we bring them home and so forth? So I want to give you an example of a case from start to finish. It happened because someone on Facebook posted, oh, you should call Suzanne. And then someone else said, oh, you should call Suzanne. And then someone else said, oh, you should call Suzanne. So I had 3 calls in one day from 3 different people, all very similar. Okay, but I want to focus in on this one daughter who, in my opinion, was an amazing advocate, okay, and was doing everything right, but was being told everything wrong. So her father was in the nursing home in November, fell, broke his hip, went through rehab. I get the call around January 23rd. Okay, we're coming to the very end of a 100-day rehab stay. The social worker from the MLTC said, you'll never get 24-hour care, so she was just trying for 12 hours of care. She had 49 to start with, okay? So I always like to start by reviewing the medical information. So I got hospital, the subacute rehab admission report, the PT/OT certifications that I'm looking through. This man has a stage 3 sacral wound. He is frequently incontinent of bladder and bowel. He had a police report that was so extensive of not being able to get out of a chair after the 49 hours. So I said to the daughter, I said, why are you going for 12? Like, is this what you want? Do you have coverage in the evening? She goes, no, I just was told I would never get it. So in the 11th hour, we had to rescind the first appeal and go for 24-hour split shift care. Everything had to be expedited because now we're dealing with a change in payer source. We're going off of Medicare rehab days to now, you know, a Medicaid chronic care stay. So that all has to be negotiated. The stress level is beyond belief. Around February 14th, I believe, we won the 24-hour split shift care. Okay, it was an easy case. Okay, and I just want to share with you, we're winning all the time. Okay, the managed care is not winning. The day the managed care starts winning, I will probably take on a different kind of job. Okay, so just remember that. Okay. I did an expedited external appeal, and I always try to do those first because I could be done in 72 hours. Okay, and I will tell you, I have not had to go to a fair hearing in the last 6 months because the appeals at the Department of Financial level have been working very well. Once in a while, we go through road bumps, and advocates will get together, and we'll all start, you know, complaining and whatever, and so forth. But it has been going very well. Fair hearings have gone well for me. I have a great track record, not because I'm great. I'd like to think I'm good at what I do, but we're winning because, as Valerie said before, the policies are clear, okay? So important information. You have everything, you got everything you need today to become an advocate on your own. I learned everything by reading everything Valerie and her organization put out. I taught myself how to be an advocate. So it's not rocket science. You have the policies, you have the information that you need to empower you, okay? Now I'm sharing the last part to the story is, because it has to be a PPL story, I gotta end on that. So here we are, we won 168 hours. I did my job, I'm done. I get a call back from this great advocate daughter and said, and this is the 3rd week of February now, I was just told my dad can't go home till April 1st. And I'm like, what? So it was Thursday at 4:45, and I said, but I don't understand. She goes, well, I don't trust this case manager anymore because she's lied to me so many times. So I don't know if it's the MLTC, but the fiscal intermediary, because at this point we haven't transitioned over to PPL yet, said that, no, you've been in the rehab too long, you're a brand new case, okay? Which, not correct. A reauthorization for more hours needed to go to the fiscal. But the fiscal was saying, we're done, we're done. So what does an advocate do when they need an advocate? Well, I first said to the fiscal, I said, I'm gonna give you, I said, please speak to your supervisor. This does not sound right to me, and I'm gonna give you a chance to do the right thing. So 15 minutes later, I get a call back, and I was almost like, don't make me do it. So basically, I think, don't make me do this. So 15 minutes later, nope, we're right. We're not going to, we can't take on the case. It's PPL's situation now. So I was like, okay, I'm going to reach out to the top advocates. Because as Lou said, advocates sometimes need advocates. So I think I looked at my email. I think it was 6:15. I emailed the healthcare advocate listserv that I'm part of. And I'm like, I have a situation and I have no idea what's going on, but it doesn't seem right. I think Valerie's responded like at 10:50 at night. I had another top advocate the next morning. I had, P.S., we had this daughter really with the governor's office. Like it it just went totally up to the top. But again, yes, it was Suzanne, the other Suzanne, who was wonderful. And I have to say, this was my one client. What about all the other ones? The tip of the iceberg I had, but what about all the other ones now are sitting in a nursing home waiting now till April 1st? And even if PPL registered them all. So what I wanted to leave parting words with is become an expert in Medicaid policy. Like I said, you have everything you need today. You have all Valerie's slides. Learn what you need to learn. Provide families with accurate information. Even if you are that MLTC case manager that has some kind of weird mandate. I'm mad at United Healthcare because my stock is tanking today. So even if you have this mandate of cost effective, don't lie to your clients. You know, tell them this is a journey, you have rights, help them along the timeline, but don't lie. I just don't think social workers with a code of ethics would want to be doing that. And it's bothering me that it does happen all the time. File complaints when necessary, okay? So like when things are not going timeline-wise, like this case manager didn't do an assessment organize an assessment timely, they didn't issue a denial letter timely, those are all valid complaints to go to DOH. They do respond to complaints such as that. I have been very lucky and very effective in getting things moved faster by my complaints with DOH. So take advantage of that. File grievances against the managed care plan. Hold them to task. This daughter was so burnt out because she was like tired and constantly on this turmoil journey of dealing with this. I helped write her complaint letter because I felt it was that important. I said, I know you don't have energy to do this. I will help you do this, but we need to do this. Hold them to task. At some point, they're going to have to answer those complaints. I don't know where the complaints go, you know, but I do know the complaints, I don't know if they go beyond the MLTC, but I do know every time a complaint was filed, my client got a response back. And maybe next time that case manager won't lie. Maybe they will, maybe they won't. I hope they don't. And then again, seek higher level of assistance because again, advocates need advocates. I only feel good about what I do because I know when I don't know something, I know where to turn to. And then really that's what I wanted to share with my peeps today, the social workers in the community. So thank you. Thank you for having me, Lou. Thank you, Aaron. Thank you.
Thank you, everyone.
For those of you still with us, thank you. For those of you still on virtually, thank you. I want to remind everyone to complete your yellow evaluation form. They will be collected as you leave and exit. We ran it right up almost till 4 o'clock, so we don't have a lot of time for questions. I'll be hanging around after. I'm sure some of the speakers will as well if you have personal questions. But thank all of you. I want to thank especially our sponsors and our speakers for making today possible. And we hope to see you for the next 30 years here at the Elder Law, well, not me, but somebody, for the Elder Law Forum.